Well, thank you everybody for allowing me to be here and speak with about some topics I love and are dear to my heart. For those of you who don't know me, I'm Steve Brown. I'm an endocrinologist at the Tanner Clinic and been here for about 3 years. So when I first got approached to talk about this, and the topic was what's new in endocrinology, diabetes, I thought to myself, what isn't new in diabetes this year in the last couple of years? And so in a quick topic discussion today, I'll try and cover as much as I can. Thank you. And I am a little taller than most people. So I don't have any relevant financial disclosures at this point. So we're going to start today by discussing a case report with you, and then talk about diabetes and population health, cardiovascular risk management, and then also other advances in diabetes care, as well as some advances that have occurred in hypoglycemia care. So my case report is I encountered a gentleman a few years ago who's a 67-year-old guy, history of type 2 diabetes, hypertension, hyperlipidemia, and peripheral neuropathy. And he presented to me from his primary care because his insulin requirements had gone up quite a bit. His primary care was managing his diabetes, but because of a rapid increase over about 6 weeks in his insulin dosing, he came to me. So otherwise, his medical history was unremarkable, and his medications were typical for those who have diabetes. He was only on a long-acting insulin and was not on any short-acting insulin. His physical exam was unremarkable. His A1C had gone up from 7.2 to 7.5, so just a small increase. And his long-acting insulin he had been given instructions to titrate this up as his sugars were elevated, and they continued to be in the 200 to 250 range in the morning. And 6 weeks before I saw him, he was on 25 units of insulin, and then he went up to about 450 units of insulin in that short period of time. And so I asked myself, what in the world is happening with this guy? And so I began to talk with him. I usually go through a few things about how are you dosing, when are you dosing, your techniques, etc., making sure they're actually taking doses, not missing doses of insulin. And he appeared to be doing everything right. And so I brought him back a second time and again gave him instructions on to titrate up. And he was on even more insulin the second time I saw him. So I tried to figure out what was going on. He didn't look Cushingoid. He didn't appear to have anything else abnormal going on. And when I was refilling one of his medications, I asked him, how many pens do you go through on a daily basis? Because he needed quite a few, going through 450 units a day. And he said, well, one pen usually lasts about 2 weeks. And I said, that can't be true. And he assured me that was true. And so we got to talking a little bit more, and I had him come into my office the next visit to see how he injected. And if you know the insulin pens, they have a little button on the top of that. So he would dial up his dose, and then he would dial it back down. And then he would dial back up, and then dial back down, never hitting the button to actually inject the insulin inside of him. So long story short, a little bit of delving into his issue explained the problem with why he was on such high amounts of insulin. And I got him on just metformin, and he's done well since then. So one of my biggest things I see is talking to patients about diabetes. Education is key to helping people who don't understand diabetes take care of themselves. And in the ADA statement here, for optimal outcomes, diabetes care must be individualized for each patient. And I want to talk about a few of these areas in terms of individualizing diabetes care. One approach to individualization of taking care of diabetes patients is figuring out what is your A1C goal. And this needs to be different for each patient. If you have a patient that comes in who is at a high risk for hypoglycemia, don't try and push them low because it will complicate things. They'll end up in the hospital. If you have someone who's had the disease for 70 years, we can probably back off at this point and have an A1C closer to 8 instead of down by 6.5. If you have a cancer patient who has 2 months to live, don't kill them with hypoglycemia, please. If they have a lot of comorbidities, including vascular complications, we want to be a little bit less aggressive. And then if you have someone who's not very well motivated to achieve a good goal, that would be also someone not to push too hard because you'll drive yourself crazy doing so. And last of all, if they don't have resources and a good support system, maybe have a different goal. Medication adherence is one thing I see a lot. How often do you actually ask your patients if they're taking their medications? A lot of them will say, yes, I'm on this, but a lot of the time they're not actually taking it. Sometimes it's too costly. Sometimes they have side effects, and I find a lot of people on metformin who are just having tons of GI symptoms, and because of that, they don't take their medication anymore, but they're too embarrassed to tell their provider because the provider tells them how good of a medication it is. Lifestyle, I have to put a plug in for this. I have an exercise science background before I went into medicine. Lifestyle is so important. Every patient I see, I talk about this. And it's recommended to have at least 150 minutes a week of a moderate intensity activity in order to help prevent diabetes if you're pre-diabetic, or to help with weight gain that's associated with a lot of our medications. Don't be afraid to use metformin as well to prevent type 2 diabetes. It is approved, FDA approved for this purpose. And if they are at high risk for developing diabetes, please go ahead and start that. This is a fairly busy slide that I want to go over. When you have someone who you're starting on medications, which medications do you use? And nowadays we have a lot more medication choices to go through. And the first question, you should always start metformin and lifestyle recommendations if they tolerate metformin. Second, you want to assess if they have cardiovascular disease or not. And if they do, you want to go down the left side of the algorithm, including if they do have high risk or they have known cardiovascular disease, you want to probably start a GLP-1 receptor agonist that has properties of lowering cardiovascular risk, or an SGLT2 inhibitor. If they have heart failure, you're going to want to go down the SGLT2 inhibitor route. And if they have CKD, then both SGLT2 and GLP-1 agonists are going to be your choice. If they don't have cardiovascular disease, then you have a couple options. So if it's hypoglycemia you want to avoid, then a GLP-1 agonist, a DPP-4 inhibitor, or an SGLT2 inhibitor would probably be preferred. Pioglitazone is another great medication, but unfortunately pioglitazone usually adds weight to them. If it's cost that you're looking at, the two medications are going to be a sulfonylurea or pioglitazone, which are still generic at this point. And if you need weight loss, then the GLP-1 receptor agonists and the SGLT2 inhibitors would be preferred. In terms of cardiovascular risk management, hypertension is another issue. I won't spend much time on this slide, but if they are above their goal of 140 over 90, then go ahead and start one medication that if they have protein in their urine or CAD, then an ACE inhibitor or an ARB is going to be preferred. If not, you have several different options you can go with. This is a slide that I put together about SGLT2 inhibitors. Cardiovascular outcome trials are a huge topic in both the cardiovascular world and the endocrinology world right now. And I wanted to summarize some of the findings through these trials. So dapagliflozin, canagliflozin, ertigliflozin, and empagliflozin are the four main SGLT2 inhibitors on the market. They, as you can see, in terms of cardiovascular disease reduction, all three of the four do a good job with that. And likely this is going to be a class effect. It reduces heart failure, hospitalizations, cardiovascular death. Ertigliflozin was the last one on the market, and their data hasn't come out with this yet. In terms of renal effects, as you notice, it reduces end-stage kidney disease, kidney function decline, and also a doubling of the serum creatinine. So all these medications have both good kidney and heart benefits, as well as lowering glucose levels. Once a patient gets down below a GFR of about 30, this class does not work very well in terms of lowering A1C, but it will still provide these benefits for the patient. GLP-1 agonists, again, cardiovascular outcome trial comparison. We have more options here. In terms of 3-point MACE, you're going to look at dulaglutide, liraglutide, and subcutaneous semaglutide. In terms of cardiovascular death reduction, liraglutide and oral semaglutide, which we'll talk about in a second, will reduce that risk. If you do notice, there is none of them that help with fatal or non-fatal MI, and also heart failure hospitalizations. And then all-cause mortality, exenatide, liraglutide, and oral semaglutide will help decrease all-cause mortality. There was a trial recently with dulaglutide that came out. Dulaglutide used to only go up to 1.5 milligrams a day or a week. And about last year around this time, they got the indication to increase up to 4.5 milligrams. The primary outcome of this study was to show superiority at a higher dose of the medication to reduce A1C, and a secondary outcome was superiority in change in body weight. And it met significance for both those categories, where it reduced the A1C by 1.7% compared to 1.5%, which was significant, and also weight loss of negative 4.6 kilograms versus 3 kilograms. And so the conclusion of this study, which got them their higher dose indication, is that higher doses are superior to the lower doses with similar GI effects. And I have found this in practice to be pretty true, where I was worried at first that they were going to have a lot more GI side effects with the higher doses, and that really hasn't proven true so far. Oral semaglutide is a medication that came out. It's the only oral GLP-1 agonist out there, and it's marketed under the name Rybelsus. It has 3 main doses. You start your patients on a small dose at 3 milligrams a day, and do that for 30 days so they get accustomed to the GI side effects that can be associated with it. Then you'll go up to 7 and 14 milligrams. It is an oral medication. You must take it 30 minutes before eating, or else it will be ineffective. And side effects are very similar to subcutaneous semaglutide. The only problem sometimes is cost and getting insurance to cover this. Inhaled insulin is not really new, but it's kind of newer. Inhaled insulin is a rapid-acting insulin, so they would have to take a long-acting insulin as well as this for meals. It is approved in type 1 diabetes, and when compared to injections, it has no higher risk of hypoglycemia or weight gain. In fact, it may reduce postprandial hypoglycemia because it's a little shorter acting. It is contraindicated in those who have lung disease, so asthma, COPD, etc. And it's not recommended in people who are actively smoking. The one downside to this is that you do need to monitor spirometry. It's recommended by the FDA to do this at least once a year to check FEV1 to make sure there's no decline in their FEV1. Smart pens and technology. So smart pens are fairly new in the game. Diabetes technology has come a long ways for those who are familiar with pumps and smart pens. Smart pens can help calculate insulin doses. You put in your blood sugar, you have a carbohydrate ratio and a correction factor, and this takes out the calculation part for the patient. It also factors in insulin time, which will help from them overcorrecting sometimes. It can go down to half unit doses. It gives reminders for the patient to give their insulin. In fact, I had a download on one of my patients on one of these yesterday, and it told me he missed 44 doses. And I said, what's going on? So it helps you as a provider take care of them. It will also notify you if you're exceeding temperature, if your insulin is expired. It is interactive with technology, so we can download these and get very good reports. And it also works with smartphones and watches, which is very important for the younger generation of diabetes. Just a brief slide about continuous glucose monitors. So there's mainly 3 out there. Medtronic has the Guardian, Dexcom, currently the G6, and then the Freestyle Libre 2 is out. Insurance in terms of coverage is going to require about 30 days of sugar readings. Some insurances do cover or require 90 days instead. And so if you refer someone to me, just know that I can't get that approved without that, and I only have the same capabilities probably as you do in getting those approved through insurance. Insulin pumps are a great device to help control diabetes. They are a tool and they don't control their diabetes. It still requires a lot of effort on the patient's part. Medtronic is currently the most updated version is the 770G. It has high and low predictions, and it can also pair with their sensor, the Guardian sensor. It does now have Bluetooth capabilities, which was a problem in the past, and it can self-adjust the basal rates in order to help the patient lower down their blood sugars if they miscalculate doses. Tandem has a T-Slim pump. It also can do high and low predictions. It does self-adjust. The advantage of the T-Slim over maybe the Medtronic is that it can do microboluses, which helps bring those sugars back down a lot quicker rather than just the increase in the basal rate. It pairs up with the Dexcom sensor, which has an advantage that it doesn't have any calibration. So the Medtronic patients on the Guardian will still have to poke themselves twice a day in order to calibrate their sensor. And Medtronic is working on that, and the next version of their sensor should be a non-calibration. Omnipod is the third pump. Currently, it does not pair with a CGM, and it is a tubeless system, so which is a huge advantage to a lot of patients who don't want to be tied down to a tube system. The last topic I wanted to discuss real quick is just glucagon and treatment of hypoglycemia. So if you have a patient who is on short-acting insulin and is at higher risk for hypoglycemia, you should know how to, or teach them how to treat that. First of all, obviously, is the rule of 15 grams of carbohydrates every 15 minutes for a sugar below 70. And also have a glucagon pen prescribed to them for emergency situations if they're unable to take oral glucose. There's a few advances in glucagon. If you're familiar with the old glucagon administration, you had to mix it up in a vial, draw it out in a syringe, and I guarantee anybody who is panicked at the time and is trying to do this for their loved one is not going to be in the right mind to probably do that in general unless they practiced. So now there's a couple pre-filled syringes and auto-injectors out on the market that don't require them to mix anything up and just pull it out of the packages and inject. Gvoke is one of the two. It's a 1 milligram or a 0.5 milligram dose, depending on if you're pediatric or adult. It is approved for ages 2 years and up. And like I said, it is a pre-filled syringe. The half-life or the shelf life on Gvoke is approximately 2 years, and so it can last for that long, and they don't have to replace that as frequent. Zegalogue or dasiglucagon is very new, within the last probably 6 months or so approved. It's approved for ages 4 and older, and it is also a pre-filled syringe and auto-injector. Just remember, contraindications are going to be if they have a history of pheochromocytoma or insulinoma. If they have that, they're probably going to be seeing me anyway. Side effects, the side effects of glucagon are going to be nausea, vomiting, injection site reaction. That's better than a coma, we'll say that. The dasiglucagon trial that got the medication approved was a randomized double-blind trial. It compared dasiglucagon at 0.6 milligrams to placebo and then glucagon, the regular injections. Primary outcome was time to glucose recovery, which was measured by an increase in blood sugar by 20 milligrams per deciliter. Dasiglucagon, it took about 10 minutes. Placebo was 40 minutes, and I really feel bad for those patients who suffered that long. And regular glucagon was about 12 minutes. So you can see there's about a 2-minute difference in recovery on that, which 2 minutes in a hypoglycemic state can be a long time for a patient. Dasiglucagon, like I mentioned before, a little bit quicker time to recovery. It does have a 3-year shelf life compared to a 2, and it can be refrigerated. And the last glucagon method I want to talk about is a nasal powder, which is easier than an injection. And it's a 3 milligram dose marketed under the name of Baqsimi. It is the only nasal glucagon and is approved for ages 4 years and older. Same contraindications, and the only disadvantage really to this is that it causes some upper respiratory tract irritation. And that's all I got for you. Any questions?
What are those costs?
The question is, how much does it cost? So for a commercially insured patient with a copay card, it's usually about $25 for 2 pens, so pretty affordable if you have commercial insurance. A little bit harder with Medicare and Medicaid plans. You have to go through the prior authorization process, and it obviously can be a lot more expensive if it's not covered by insurance.